Thank you. It's a great honor to contribute to this meeting, and I'd like to thank the Korean Society of Nephrology, the organizing committee, and KDIGO for the kind invitation to give a presentation. These are my disclosures. They have not affected what I'm going to say. In the next 30 minutes, I will cover the spectrum of kidney disease, from acute kidney injury to acute kidney disease and chronic kidney disease. Conceptually, this is displayed in the figure here, where we have the full trajectory of kidney disease from normal kidney function to total kidney failure. Most people are born with normal kidney function. And at some point, some patients are exposed to a nephrotoxic insult, which may lead to kidney damage. If this progresses, kidney function may decrease, and in fact, kidney failure may occur. This process is often reversible, but if the underlying disease is not reversed, kidney function may deteriorate completely and kidney failure may set in. During this time, patients are at high risk of not only renal complications, but also complications in non-renal organs and increased mortality. By consensus, we've agreed that 3 months is the cutoff. So kidney disease lasting for more than 3 months has been, by consensus, labeled as being chronic kidney disease. In the last 10 years, we've learned a lot about acute kidney injury, and there is increasing awareness of the immediate and long-term complications. Patients suffering from acute kidney injury are at high risk of developing severe acute kidney failure, needing renal replacement therapy, but they're also at risk of failure of other organs, in particular cardiac complications and pulmonary complications. In the long term, patients who survived acute kidney injury remain at risk of complications, in particular premature chronic kidney disease and premature end-stage kidney disease. But they're also at risk of cardiovascular complications and cerebral vascular complications, including stroke. And clearly, acute kidney injury and its complications are major contributors to healthcare costs. Chronic kidney disease is a feared complication of acute kidney injury. And again, our knowledge has increased significantly in the last few years. And we now know that acute kidney injury leaves a scar within the kidneys, resulting in scarring, fibrosis, and the development of chronic kidney damage. Conceptually, we now know much more about acute kidney injury, thanks to the publication of the acute kidney injury KDIGO guideline from 2012. We also have a clear definition for acute kidney injury, as shown here. By consensus, it is defined by a rise in creatinine or a fall in urine output. And certainly in the last 8 years, clinicians and researchers have used this definition in clinical practice and for research studies. And this was clearly a major breakthrough. Since then, knowledge has improved, but with that, we've also come across various uncertainties and lack of consensus. For instance, As shown here, the trajectories after acute kidney injury are very variable. Some patients develop acute kidney injury but recover kidney function very quickly, as shown in this green line. Others take a bit longer, and in some patients, kidney function recovers, but acute kidney injury recurs, as shown in the black line. And for some patients, kidney function never recovers, and they remain often dialysis dependent, as shown in the red line. To date, recovery and recurrent AKI has not been defined by consensus, and more work is necessary. Furthermore, it's been recognized that there are patients with clear evidence of acute kidney disease who are not captured by the current AKI definition. As an example, patients may have a flare of glomerulonephritis with clear evidence of inflammation on renal biopsy and evidence of hematuria and proteinuria, indicating an acute inflammatory disease. But creatinine may not always meet the criteria for acute kidney injury. Similarly, patients with unilateral obstruction may have significant kidney disease in the obstructed kidney without a rising creatinine. And again, patients may not meet the criteria for AKI. This was acknowledged by the KDIGO working group in 2012. And in response, the group proposed the term AKD, which stands for acute kidney disease and disorders. And as displayed here in the figure, the expert team proposed to use AKD for acute kidney disorders lasting up to 3 months. And as shown here, AKI forms a subgroup of AKD. Since then, we've certainly learned that AKD, similar to AKI, is associated with significant short and also long-term complications. Patients with prolonged acute kidney disease are at risk of developing chronic kidney disease and becoming dialysis dependent. And they're also at risk of various non-renal complications, in particular cardiovascular complications. The fact that AKD is a serious health risk was highlighted by this publication from the team in Alberta in Canada. And to date, this is certainly the largest publication highlighting the importance of AKD. The team performed a retrospective analysis of patients living in Alberta. They included all those who had at least one creatinine result during a 12-month period in 2008. The aim was to characterize the incidence and outcome of AKD in the following 8 years. And for this purpose, they obviously excluded patients with pre-existing end-stage kidney disease. The team focused on laboratory results only, without any further clinical information. And for this purpose, they agreed some definitions for AKI, AKD, and no kidney disease. The analysis was based on creatinine results alone, and therefore they defined AKI based on the KDIGO definition. Ultimately, it was defined by creatinine rise by 0.3 milligrams per deciliter or more over a 2-day period, or an increase or decrease over a subsequent 7 days within 3 months. AKD was defined by an estimated GFR of less than 60 mils per minute on the index day in those who either had a normal eGFR in the preceding period or no albuminuria and no existing eGFR results. In addition, they also defined AKD by a decrease in estimated GFR of 35% or more, or an increase in creatinine in patients who did not meet AKI criteria. And lastly, by consensus, no kidney disease was defined by an estimated GFR of greater than 60 mils per minute on the index day and in the past. So these were the pragmatic criteria for the definition of AKI, AKD, and no kidney disease. Using these criteria in patients who had a creatinine result available, they showed that AKI was indeed quite common, affecting 42% of patients. But strikingly, AKD without pre-existing AKI was much more common. And this was clearly a surprise finding. When they went further and looked at the outcome of patients with AKD, they demonstrated that this cohort of patients had a higher risk of developing end-stage kidney disease compared to those without kidney disease. And this is displayed here in the gray line at the bottom. They also had a higher risk of dying in the subsequent 8 years compared to patients without kidney disease. And the risk was particularly high in patients who had pre-existing chronic kidney disease, as shown here in this dark gray line. The main findings of this large analysis was that AKD was much more common than expected. In fact, it was 2.7 times more common than AKI. AKD patients were characterized by being older and having more comorbidities. And importantly, the majority of AKD actually occurred in outpatients rather than hospitalized patients. And as I've already shown, patients with AKD were at increased risk of dying or developing dialysis-dependent kidney disease in the following 8 years compared to patients without kidney disease. This is clearly a very important study highlighting the fact that AKD represents a high-risk disease and may well be undetected, especially if it is, since it is more common in the outpatient setting. It's important to recognize and acknowledge some limitations. In this study, the classification and categorization of patients was based on single creatinine values without any clinical context. And that's important. It's also important to acknowledge that the etiology of AKD remains unclear in this cohort. Clearly, more work is necessary and more work is required to agree a consensus definition for AKD. The AKI group in 2016 also focused on recovery and the development of acute kidney disease in contrast to AKI. And the meeting in 2016 aimed to propose definitions and staging criteria for recovery after AKI, and AKD and its management. And this working group proposed to use the term AKD for the period between day 7 and day 90. And as displayed here, we see a clear differentiation between AKI and AKD, where AKD forms the bridge between AKI and CKD. And this is clearly in contrast to the previous proposal from the KDIGO expert group. Another conceptual model for AKD and acute kidney injury and chronic kidney disease is displayed here, where we could propose to say, well, we distinguish between AKD up to 3 months and CKD from 3 months onwards. And AKI may represent any acute deterioration of kidney function, which could happen at any time, either before the 3 months period or in patients with existing CKD. Similarly, AKD may occur in patients with pre-existing CKD. So we now have various different models, all trying to improve the understanding of acute and chronic kidney disease. But clearly, harmonization is necessary in order to progress in this field and in order to develop research studies and intervention studies. And the fact for more consensus was highlighted in a KDIGO controversies meeting, which was held in April 2019. This meeting aimed to review key relevant literature published since the original KDIGO guideline in 2012 and to identify ongoing controversial issues. And the controversies around the definition of AKD were highlighted in particular. The expert group concluded that there was an urgent need for consensus on the exact criteria and the indicators of severity of AKD. There was also an urgent need to assess and examine the clinical importance of AKD in more detail. Clearly, the study by James et al. And colleagues already highlighted some of the potential outcomes, but more work is necessary to understand AKD better. And the group recommended that a revised definition and classification of AKD needed to be harmonized with the existing definitions of AKI and CKD. And it also needed to tie with clinical management. So universally, there is a call for a clearer understanding and a clearer definition for AKD. In response, KDIGO organized a meeting to achieve exactly this. The meeting was called a consensus conference to harmonize acute and chronic kidney disease definition and classification. It was a virtual meeting, and as shown here, where I show you a copy of the screen, it was attended by a large number of international experts from nephrology and critical care, representing clinicians and researchers. And the aim of the meeting was to agree a precise patient-centered definition and recognition of AKD. Furthermore, the group felt it was important to outline the diagnostic approach and the management of this high-risk group, in particular, the role of diagnostic tests, including renal biopsies, the management and the follow-up. Furthermore, the the group aimed to describe the existing data on clinical impact and prognosis, and aimed to agree some implementation strategies. To date, 2 meetings were held in August. A lot of discussion has already happened, and the group has agreed that kidney disease should be defined as abnormalities of kidney structure with implications for health. There's ongoing work and ongoing discussion about the exact criteria for AKD. A follow-up meeting is planned for October, and clearly the results will be disseminated and published afterwards. So in conclusion, KDIGO has made a significant contribution not only to the definition of AKI, but also highlighting the importance of AKD, since the studies so far show that AKD appears to be more common than AKI. To date, the exact definition of AKD remains unclear, but there is a clear commitment to determine the criteria and its best management. Once criteria have been agreed, there will be an urgent need for further research and, more importantly, for intervention studies. And as outlined by the team in Alberta, patients, the majority of patients may not be hospitalized. They may be outpatients, patients seen by primary care or other specialties. And this highlights the need for multidisciplinary working and multidisciplinary collaboration in order to improve the outcome of patients with AKD. Thank you very much for listening. I'd also like to thank the Korean Society of Nephrology for inviting me, and the KDIGO team for their support and the honor to present this work. Thank you.